Good morning, everyone. I'm very pleased to be again here in Barcelona. I have been here since 2009, several times, talking with TIC Salut and influencers, and I am very glad that Catalonia has been so fast-moving in the sense of eHealth. But I'm coming from Estonia, and probably you know that Estonia is one of the leading countries in developing of e-services and eHealth in part of it. And I've been involved in most of the developments. So today I will talk about a journey which starting with digitalization and probably we are in the middle of the long journey, and I tried to give some vision of how we have moved and where we are moving. First, we started, all of us, in digitalization. We developed electronic medical record in one institution. Could it be a hospital information system or just a family doctor office or dental care? But it is one institution and one medical record. It is not shared. It's inside the one institution. In the same time, we see that there is a different concept which is called personal health record. And many of us are using different devices like measuring our steps, our pulse, our glucose and other biosignals and collecting these data somewhere. In Health One, we also see first services which are provided using artificial intelligence. But these services are very small and very easy services like search engines and decision support of using guidelines and developing these guidelines. So this is Health One, so this is digitalization. Health Two is more complicated, and most of the countries worldwide are struggling to get this integration done. Integration means that health information have to be shared between institutions. There is two different concepts. First is electronic health record, which is like a countrywide or regional record. Basically, it is one software, and it is used by hospitals, by GPs, by different professionals. But still, it is in one shared record system. The other option is health information exchange. And the health information exchange is the way how Estonia started to integrate the different healthcare providers. Health information exchange means that we have different softwares. Each of the institutions may have different solutions, but they have to share the data between each other. So we need some kind of intermediator or integrator between these different softwares. And in Estonia, it is done in central way. So we have one health information exchange platform, and everyone is sharing data or sending data to this platform and getting answers from this platform. So this is health information exchange. Now we see that also this personal health domain have moved further. And for example, Apple have integrated different devices. You may use your Apple Health, and you can integrate different devices to your personal mobile phone, but there is a different ecosystem of devices. So there is also integration that you have one platform, but many devices. Nowadays, we already see in these systems more sophisticated artificial intelligence or decision support systems as well. For example, in Estonia, we have a drug interaction service, which means that when I write prescription, in the same time, I get announcement from this decision support that this drug may have some contraindicators or some kind of conflict with other drugs what patient is already using. So this service is implemented as a part of the data exchange platform. So it's an independent service using the data. So these three different categories like data exchange, personal level, and decision support are three technologies what are influencing healthcare and e-health. So, and this is where most of the countries are struggling to get this kind of integration done. So what has been the driving forces in Estonia? In Estonia, we can name that very interesting thing is that the financing of the e-health development is not coming from the Ministry of Health. Because in the top priorities of the Ministry of Health has never been e-health. There is a lot of other burdens that social and healthcare should deliver. So this has come directly from the Ministry of Economy and Communication. Maybe this is something to think about. The second thing is, if you implement e-health services, you have to be very clear governance model. Who is responsible of delivering these services? And in Estonia, we founded a special organization for that. It was called eHealth Foundation. Now it's merged and with the IT department of Ministry of Health, and it's now called Estonian Health and Welfare Information Center, and they are handling the health information exchange services. Legal clarity, extremely important. Since 2002, Estonia have legislation which declares that every data which is collected about you belongs to you. So you are the owner of your data. And it does not matter what kind of data. Everything belongs to the citizen. So another thing is that we need a mature ecosystem for infrastructure for secure data exchange. And Estonia has established this kind of secure data exchange since 2002. And part of it is strong authentication tools, mobile ID, smart ID, which is software-based authentication tool. And we allow only strong authentication, which is allowed to use in these ecosystems. Another important thing is about agreement of access rights. Who can access your data? And in Estonia, we decided that every doctor, every medical professional is equal to access to your data without any restrictions. But as a patient, you have right to refuse to share the data. So you can opt out of data sharing. But as a professionals, they have obligation to send agreed amount of medical data to the data exchange platform. During 10 years of implementation, this system is up and running since 2009. We have only 400 people from 1.4 million who have refused to share the data. It's less than 0.0%. So if you design a system of data exchange according to this 0.0% of users, then the system will come not usable because of so many restrictions. And another important thing is standardization. Medical data, content data, but also the data exchange data should be standardized. So what we have achieved And this is a graph which explains very roughly how the healthcare system is working today. The study which is used here is published in Canada, and by this study there was a question by the adult people how often they have health-related problems. And 80% said that during last month I had something about my health. Now 329 of them decided that this is so severe that they have to see the doctors, and they become a patient. Becoming a patient, they will struggling inside the healthcare system. They will get diagnosed, they are sent to another specialist or laboratory. Finally, hopefully, all this data will come in structured form to the electronic health record system, and data can be shared between others inside the professions. However, as a medical professional and also a person who have long experience with implementing IT systems, I have several concerns here. What happened to those 471 who decided not to become a patient, but solved their health-related problem somehow? We even don't know what was the problem because we are not collecting this information. We are collecting only information about sickness episodes. So about this data which will deliver through the electronic medical records. But what happens with these healthy people otherwise, we don't know. Were these 329 right ones who became patients? Or how many of those 471 should go and really see what is the right proportions? We don't know because we are not having this data. So, as I told, the experience what Estonia has gained has been a long journey. So, we have a pointer? Okay. So we started somewhere early in the end of last century, establishing medical records in the institutions. Then we started to prepare European structure-funded project. We established eHealth Foundation, and the project was 2006 to 2009, and then the National Electronic Health Record System or Health Information Change was placed in 2009. E-prescriptions and all other services followed, and now we are moving to the Health 3.0, establishing decision support, pharmacogenetics, profiling, and personal health accounts. And this was signed, this project was signed 2 weeks ago by the ministry, and now during 2 years we will establish this kind of Health 3.0 services. What they look like. So I think personally that if we can implement different types of AI services which will help those 800 to discover what is the real cause of the problem, like using this kind of symptom checker type of algorithm, then extraction of the data what you have previously provided in the medical records and also in personal health records, then following with data analytics and decision making, we can recommend more precise service to the citizen who are having some health-related concerns. But in the same time, we know that most of the cases can be guided to the self-care. Sometimes just giving information that don't worry, this is a normal physiology. You need some rest or some vacation, or maybe you have to increase your physical activity to overcome the stress, helps you more than seeing a doctor. So but we are not using these opportunities today. And because of that, I think that there is some studies which show that if you implement symptom checker before ending to the doctor's office, you only have to send forward about 20% of these 800. It means 169, not 329, as if they decide themselves. So then right persons or right patients will find the right services quicker, and there is a less unused resources, and you can resource in better way. So to connect these two, professional record and self-handled records, we need something which is between them. And this is health account. I will explain what is the health account is, but in the future, the main data flow is not through the electronic medical records, but mostly the data is circling in this circle. And this is something that we haven't reached yet. We're still focusing to integration in this level. But this is only partial data set that we need for better decision making. So there is a certain preconditions, and some of them are first precondition to establish health-free services is personal data ownership. This is crucial. Without personal data ownership, we are not able to deliver any health-free type of services. Health account or something like similar could be another precondition. Then these AI services should be also integrated to this ecosystem. And not only for the professionals, but directly to the citizens, because they have the most important data. Sometimes we need different types of interpretation services because the amount of data is huge, and probably no one can use all the data in the one decision-making moment. So we need some kind of analytical tools to interpret the service. Maybe we even need a new professional which is helping citizens and also professionals to understand what is data and how we can make from data knowledge and how we can feed back this to decision making. And of course, then we can have a patient involvement. Basically, this cubic has been my interest during the last 5 years, and I have been privileged to be working together with the Finnish Innovation Fund, and we have tested all these different concepts. And some of the projects are ongoing, and we have a lot of knowledge how to implement these things. So once more, now we are collecting medical data or sickness episodes data to the electronic health record systems. Also, we have some devices, and in the future more and more different IoT things, sensors collecting our wellness and behavioral data. And now we need something like this health account. The best way to understand what is health account is to understand the similarity of data account and your bank account. In banking, you have a very simple account standard. It's called IBAN. And in the health account, we need IHAN, which is human account number. It's the similar account, but only to deliver data, not money. But the comparison, you can imagine, is the same. You are the owner of your account, you are owner of your money, and you decide with whom to share it. And it is a very simple way. You just give your account number, and anyone can deliver your data, money to your account. Why we need such a difficult infrastructure to deliver your personal data? First, the data is not yours. It is belong today to the institutions. So first we have to get ownership of over the data, and then we need an infrastructure how to be able to deliver the data and to share the data between institutions. And then you can connect different data sets. For example, your personal genomic data or data from registries. And then you can open your account for different service providers. And around it, you need a security layer. Security layer which gives you confidence, trust, secure data exchange, and other functionalities which is already today available in the market. So, why we need eHealth? eHealth, first, we have a lot of news about data breaks, different data integrity problems, and the other thing is, in EU, we have to decide, do we want to go this direction, what we have today, where the data monopoly is in Silicon Valley? Every data about us belongs to companies who are who have headquarters in Silicon Valley. Or do we want to go in other direction, like China, where the state will own your data and you have your social index according to your behavior, and state knows everything what you are doing and everything. So probably in Europe we want more human-centric, person-centric, citizen-centric approach, and eHealth gives this opportunity. Even Zuckerberg said that something that the European new protection rules is something to follow. So we have 3 basic legal acts in European level. First and most important is GDPR, the General Data Protection Regulation, which is in force since May 2018. And it's obligatory for all member states to harmonize their local legislation according to GDPR regulation. So, by the way, in Estonia, the GDPR principles were in legislations since 2002. So we have implemented these things already 17 years ago and annually using in every service. Now the other directive is eIDAS, which recognize our digital identities cross over in Europe, and PC2 regulation, which is mainly focusing to the financing data. So you can go to your bank and ask your bank to deliver all what they have collected about you to you. So now, if you look more carefully, what is the Article 20, the main article about data rights? So it declares that every citizen in Europe have right to ask all the data owners in the brackets. It means that those who have data about you, the structured way commonly used in machine-readable format. So you should go to your data provider, is it hospital, is it the family doctor, and ask your data in structured way so that you can reuse it in other services. So by legally it is possible today, but the problem is that GDPR says that we should have these things, but it does not say how. So we need GDPR 2.0, and eHealth will provide standards for that. So, and also this, that in real time, if the person gives consent to hospital, for example, please deliver my data to my family doctor. They have to do that with your consent and with your order. But there is no infrastructure and there is no rules how to do that. But GDPR gives us a basic principles. So now the good news is that we already have all the technology what is necessary for this kind of human-centric data exchange. So if you look the first in the level of the person, we have different identities. We have different ways to log in different services, but we are missing identity wallet, where all these identities will be matched together under your control. So you log in one institution using one mechanism, to other institution you're using the different mechanism to authenticate yourself. But if you have to merge these data sets, you have to somehow also merge these identities. But only you know where you have your different identities. So you need an identity wallet. Then you need to have some kind of ordering system. You can use smart contracts. You may influence also payment system here. And then in the provider side, you need to identify trustfully the service provider. You definitely need logs. Here we can use a blockchain technology, for example, and digital signature, time stamping, all these positions are there. So we are looking in the eHealth standard, we are looking 10 positions, 10 different positions, how these things should be. eHealth is now starting the European-wide standardization process together with the European standardization bodies to establish this eHealth as a common standard for data exchange. And this is not universal only for healthcare. This kind of data exchange concept may be used in other sectors as well. So it is general. eHealth does not say that you have to use this kind of that kind of technology. Here, this is like a soft standard. It will say that at least you will need to solve the problem in the level of security, but which kind of technology you are using, this is free to decide by yourself. But you have to convince the eHealth certifier that you have fulfilled all these 10 positions in the at least the minimum level of security and trust what is agreed. So that's why I'm not touching technologies which is used here, but basically in Estonian ecosystem, all these 10 positions are there since 2002. Some of them later, but now everything is there. Only thing what we are missing today is the identity wallet and consent wallet. But this is what we are now doing this for the precision medicine, and this will be available during this year. So now, why we are talking about this long journey? And the other issue is the time and money. The most expensive part of this technology-driven change in healthcare is establish electronic medical records in the institution. The per digitalization is the most expensive part. For example, in many countries, more than $100 or euros per one citizen have been spent to establish electronic medical records in the institution. Now, health information exchange is 10 times cheaper. Estonia spent $10 per one citizen to establish health information exchange and connect all the partners. Other thing is that this process took almost 15 years. Integration, another 10 years, at least. Now, if we're moving Health 3.0, I said all technology is there. Only thing what we have to invest for is agree about the standards and the regulations, what we are expecting behind of these data exchange. So if the government decides that let's do that, these are the rules, the technology and the software companies will solve the problem very quickly. So the investment by the state according is to establish this kind of health account is less than €1 per one citizen. And what's more important, it's quicker. And in developing countries, where we're also now looking at this development, it is possible to jump directly to the Health 3.0, patient-centric data exchange and collection. And in the future, the most powerful thing is when we can have this kind of agreed data exchange in the personal level, we can have AI-supported services for persons. So, and this is happening very quickly after the health account environment is in place. The market is waiting for this change, what has not happened in healthcare yet. So the last slide, just to focus that if we connect also these AI-empowered decision-making services to help citizens to get better understanding about the health and possibilities, then we solve a lot of these kind of problems in the healthcare. Thank you.